Welcome to the Human Health Campus Basic Nuclear Medicine webinar series. This webinar is entitled The Physiology and Pathophysiology of Bone Turnover and is presented by Dr. Tim van den Wyngaert from Antwerp University Hospital in Belgium. I am pleased to present this seminar to you on behalf of the Nuclear Medicine and Diagnostic Imaging section of the International Atomic Energy Agency in collaboration with the European Association of Nuclear Medicine.
This presentation will consist of two parts. In the first, we will review the mechanisms behind normal bone formation and metabolism and take a look at bone remodeling and fracture healing. In the second part, the pathophysiology of some prototype bone diseases will be reviewed, focusing on the current understanding of the pathophysiology of osteoporosis, rheumatoid arthritis, osteoarthritis, osteomyelitis, and bone metastases. Bone serves a large number of functions. It supports the human body and facilitates locomotion. It provides an appropriate environment for bone marrow. It acts as a reservoir for calcium. It assists in the metabolism of fat and glucose. It also provides a way to store growth factors and cytokines, and it assists in maintaining acid-base balance and the detoxification of in particular heavy metals. And while it may have a static appearance, bone is truly a dynamic tissue, subject to bone modeling and remodeling for adaptation and repair. This slide shows the major anatomical hallmarks of long bones. The outside of the bone consists of a layer of connective tissue called the periosteum. Additionally, the outer shell of the long bone is compact bone, followed by a deeper layer of cancellous bone, also known as spongy bone, which contains the red bone marrow. The interior part of the long bone is the medullary cavity, with the inner core of the bone cavity being composed of yellow marrow in adults and red marrow in young children. They grow primarily by elongation of the diaphysis, with an epiphysis at each end of the growing bone. The ends of the epiphyses are covered with hyaline cartilage, also known as articular cartilage. Bone is a composite tissue that exists primarily of inorganic mineral in the form of hydroxyapatite. This mineral is embedded in an organic matrix that includes a complex mix of proteins, but mostly consists of collagen type 1. The remaining percentages of bone are composed of water, lipids, and cells. And despite its static appearance, bone is a very dynamic tissue. This was already elegantly demonstrated by George de Hevesy in his 1935 paper in Nature, where he used isotopic dilution of radioactive isotopes of phosphorus to hypothesize the existence of bone turnover in rats. It is of course this discovery that many years later formed the basis of the introduction of radiolabeled bisphosphonates as bone imaging agent in nuclear medicine, as illustrated by the 1975 paper by Subramanian and colleagues. Two distinct physiological processes determine the formation, adaptation, and maintenance of bone. While both share a common set of effector mechanisms that we will discuss later in this presentation, they both serve a distinct goal. First, bone modeling is a process by which skeletal elements are shaped into the appropriate morphology, resulting in a net gain of bone mass during growth. Bone modeling occurs at a low rate throughout life and is required for the repair and adaptation to changes in mechanical loading. Characteristically, bone resorption and formation are uncoupled and occur on separate, often opposing surfaces of the bone. Disease states that are characterized by increased bone modeling include hypoparathyroidism, renal osteodystrophy, and during the treatment with anabolic agents. Bone remodeling, on the other hand, is the second process and is responsible for tissue turnover of damaged bone while maintaining bone mass. It can also contribute to adapting to changed mechanical loading of bone, and it facilitates calcium and phosphate metabolism homeostasis. However, in contrast to bone modeling, bone remodeling is characterized by coupled and balanced activities of bone resorption and formation. It occurs in packages of cells along specific sites on the same bone surface, which is mostly at the interface with the hematopoietic bone marrow. So, how does bone formation occur? The cell responsible for bone formation is the osteoblast. This cell type derives from pluripotent mesenchymal stem cell lineage, and through activation of the hedgehog or canonical Wnt beta-catenin pathways, these cells will be forced into osteoblast differentiation. By the subsequent expression of the transcription factors RUNX2 and Ostrix, the pre-osteoblast will mature into functional osteoblasts, protecting the cell from further differentiating to adipocytes. Interestingly, genetic errors in Wnt signaling pathways give rise to skeletal malformations, osteoporosis, and syndactyly, both in murine models and humans. The process of bone formation consists of three phases. First, the extracellular matrix is produced by osteoblasts. This is followed by the mineralization of this matrix, and finally, remodeling occurs to sustain the newly formed bone. Once osteoblasts end their bone-forming function, they will terminally differentiate into osteocytes, lining cells, or undergo apoptosis. Embryonic bone formation can follow two different pathways, depending on local and genetic mechanisms. When local Wnt levels are high, mesenchymal stem cells will differentiate into osteoblasts and start intramembranous bone formation by proliferating and condensing into compact nodules. The produced osteoid matrix will progressively calcify, and the entire region of calcified spicules becomes surrounded by compact mesenchymal cells that will form the periosteum. The cells on the inner surface of the periosteum also become osteoblasts and deposit osteoid matrix parallel to that of the existing spicules. In this manner, many layers of bone are formed. In contrast, when local Wnt and RUNX levels are low, mesenchymal stem cells are forced into chondrocyte lineage and endochondral bone formation is triggered. This method relies on the prior synthesis of a cartilage template by chondrocytes. Under the influence of Indian hedgehog signaling, periosteum will form, containing a layer of progenitor cells that will differentiate into osteoblasts and start secreting osteoid. This matrix will subsequently be mineralized and secondary ossification will start. As hinted on earlier, the organic bone matrix consists mostly of collagen type 1. Other proteins include osteocalcin and proteoglycans, growth factors and cytokines such as bone morphogenic protein, tumor growth factor beta, and insulin growth factor. The inorganic mineral content, on the other hand, is made of hydroxyapatite. This is a crystalline complex of calcium and phosphate that is deposited in close relation along the collagen fibers. Osteoblasts mature into lining cells or osteocytes when they cease producing bone matrix. Osteocytes are therefore terminally differentiated osteoblasts and are the most abundant cells in bone. They are interconnected through gap junctions in a syncytial network through filopoidal cellular extensions and act as mechanosensors. Depending on the input they receive, osteocytes can suppress or activate bone formation through the upregulation of SOST, resulting in sclerostin production, which is an inhibitor of Wnt signaling. On a side note, estrogen deprivation and glucose steroid use are detrimental to bone and promote osteocyte apoptosis. Another important function of bone is mineral homeostasis. Indeed, bone is a major calcium, magnesium and phosphate reservoir, and these can be released or stored by adapting bone turnover as appropriate. The initial uptake and secretion of these minerals occurs via the kidneys and the gut. Important regulators include vitamin D, parathyroid hormone, and calcitonin, as illustrated in the figure below. In brief, PTH will be secreted in response to hypocalcemia, whereas hypercalcemia will trigger calcitonin production. Drilling down on the mechanisms shown in the previous slide, you can appreciate that bone homeostasis is regulated by a large number of local and systemic factors. For example, PTH increases osteoclast activity indirectly by stimulating osteoblasts to release rankle, as shown later on. Vitamin D promotes bone mineralization, increases osteocalcin production, and the maturation of osteoclasts. Calcitonin, on the other hand, inhibits osteoclasts and induces their apoptosis. With respect to hormonal influences, the gonadal and adrenal steroids mainly affect skeletal mass. Finally, growth hormone, thyroid hormone, and insulin promote skeletal maturation and growth. As introduced earlier in this talk, bone remodeling primarily serves the purpose of replacing damaged old bone and to maintain overall skeletal integrity. This is accomplished through regulated cycles of serial activation and paracrine regulation of osteoblasts and osteoclasts in what we call a bone remodeling unit. Some interesting numbers about bone remodeling. The rate of bone turnover of the whole skeleton is approximately 10% per year, and the interval between successive remodeling events at the same location is between 2 and 5 years. The average lifespan of a bone remodeling unit is 2 to 8 months, and finally, the turnover is 10 times higher in trabecular bone compared to cortical bone. The cartoon in this summary slide gives an overview of the different phases of bone remodeling. When microfractures accumulate, bone remodeling begins with the recruitment of osteoclasts that will resorb the damaged bone. After a period of cellular reversal, osteoclasts will give way to osteoblasts that will start to repair the bone defect created by the osteoclast. The newly created osteoid will mineralize into mature bone, resulting in full repair of the original defect. So far, we have discussed the origins, mechanism, and function of osteoblasts and osteocytes. To conclude our overview of bone cell types, let's now focus on the osteoclast. These cells derive from the bone marrow macrophage monocyte lineage, or hematopoietic stem cell. They are the only cells in the human body that can resorb bone through secreting acid and the digesting enzyme cathepsin K into the space between the cell-bone interface, known as the Horship lacuna. Osteoclasts are heavily dependent on 2 cytokines for differentiation. First, the receptor activator of nuclear factor kappa B ligand, or RANKL, and the second MCSF. Paracrine signaling is crucial in the regulation of bone remodeling, and this process can be summarized as follows. After PTH stimulation, osteoblasts will start to secrete RANKL and MCSF that will in turn promote osteoclast formation and function. Osteoprotegerin, or OPG, is a decoy neutralizing receptor for RANKL and also TRAIL that prevents binding of RANKL to pre-osteoclasts and thus prevents excessive activation of bone resorption. The resulting bone resorption will lead to the release of growth factors from the resorbed matrix, including TGF-beta, PDGF, IGF-1 and IGF-2, and these will promote osteoblast maturation. The recruited pre-osteoblasts start secreting bone morphogenic protein, or BMP, followed by osteoid synthesis by mature osteoblasts. Finally, local cytokines modulate this process by stimulating formation, such as interleukin-4, interleukin-13 and interferon gamma, or stimulating resorption, such as interleukin-1, 6 or 11. Next to local signaling, systemic regulation also drives bone remodeling. Indeed, genetic, mechanical, vascular, neurological and nutritional factors are important. Interestingly, the hormonal environment can have differential effects. For example, When PTH is pulsed, it is protective and will promote bone formation. However, when PTH is continuously high, it promotes bone resorption and is thus detrimental. Another example are the opposing effects of estrogen, which protects bone, and that of glucosteroids, which, by inhibition of IGF-1, results in bone loss. To summarize the many regulators and mechanisms we have discussed in the previous slides, this cartoon summarizes the process of bone remodeling and the many local and systemic regulators that direct the effector cells, osteoblasts and osteoclasts. From a clinical point of view, it can be interesting to quantitatively monitor bone turnover. For that purpose, a number of biochemical markers have been characterized, mainly consisting of enzymes or precursors and remnants of collagen. Bone turnover markers have been developed that can be detected both in serum or urine. As illustrated on this slide, the most frequently used markers of bone resorption are the nitrogen and carbon terminal cross-linked telopeptides of collagen 1, called NTX or CTX, which can both be measured in serum and urine. However, the clinical use of these markers has been hampered by the fact that they are influenced by age, nutrition, and other confounding factors, making it difficult to standardize. Having discussed embryonic bone formation and physiological bone modeling and remodeling, let's conclude the first part of this presentation by focusing on fracture healing. Fracture is the most common large organ traumatic injury in humans, and fracture healing is one of the few postnatal processes that is truly regenerative, as bone is restored to its pre-injury cellular composition, structure and function. Nevertheless, approximately 10% of all fractures will not heal properly. All morphogenic pathways active during embryonic skeletal development are expressed during healing, and increasingly an important role for the immune system is being recognized. After fracture of a long bone, inflammation is the hallmark of initial tissue response. This is dominated by an influx of immune cells that start removing necrotic tissue and start promoting angiogenesis and tissue repair, mainly driven by TNF and interleukin-6. This inflammatory phase is anabolic with a net increase in tissue volume due to the recruitment and differentiation of stem cells regulated by BMP, PTH and Wnt. Interestingly, T regulator cells will induce an immune suppressed state that will protect the newly formed callus, developing chondrocytes and cartilage from destruction. Following the inflammatory and anabolic stage, a period of endochondral bone formation will start. This consists of periostal swelling with bone formation starting along the edge of the cartilaginous callus adjacent to the fracture line. A vascular bed will grow into the callus from the surrounding muscle sheet, mediated by VGF. Subsequently, this cartilage will mineralize and chondrocytes will mature and become apoptotic at the end of this phase. The last phase of fracture repair is in fact catabolic and characterized by coupled remodeling. The excess callus will be removed and secondary bone formation will replace the initial matrix and cartilage. As a result of these coupled cycles of osteoblast and osteoclast activity, the initial bone cortical structure is restored, the marrow space is re-established, and the vascular bed finally regresses. In the second part of this webinar, we will review recent insights into the pathophysiology of a number of prototype bone diseases, exploring the cellular and molecular mechanisms driving these processes. Let's start with osteoporosis. Osteoporosis is characterized by a low bone mass, with impaired microarchitecture and bone strength resulting in fragility fractures. It is mainly caused by a preponderance of activity of osteoclasts over osteoblasts, and while it is mostly regarded as an endocrine and estrogen deficiency mediated disease, it is also associated with chronic inflammatory diseases, bad nutrition, a side effect of some drugs, and observed in malignancy, some viral infections, hyperparathyroidism, and other disease states. The strength of bone is determined by the following factors. Bone mass is most important and defines approximately 50 to 70% of overall strength. Geometry and composition are obvious contributors to strength as well. This is followed by the mechanical stress that is exerted on the bone, in particular by muscle straining. Physical loading improves bone strength, whereas inactivity leads to higher bone turnover, which reduces bone mass and strength. The material properties of bone can be diminished by mutations in collagen or impaired gamma carboxylation of GLA proteins, which is a vitamin K dependent process. It is also seen in osteomalacia, fluoride therapy, or hypermineralization. The microstructure can be weakened by too much osteoid, as seen in delayed bone mineralization due to osteomalacia or a lack of vitamin D, or due to increased bone formation, as seen in callus or Paget's disease. The onset of osteoporosis is clearly linked with age, and the effects of aging on bone are dramatic. In summary, aging results in reduced remodeling, leading to a negative bone balance both in women and men. The number of osteoblasts will diminish as a result of lower stem cell numbers, defects in cell proliferation and differentiation leading to increased apoptosis, and diversion of progenitor cells toward the adipocyte lineage. In contrast, there is an increase in the osteoclastogenesis, as we will see in the next slide. Finally, aging results in a dramatic reduction of osteocytes, in part due to estrogen deficiency, reduced physical activity, and increased oxidative stress. The potential role of the immune system in osteoporosis has only recently been recognized. It is now clear that bone-regulating factors are also produced by immune cells, resulting in both catabolic and protective effects on bone. In particular, rancol and TNF-alpha are secreted by stimulated T cells and mature dendritic cells, and OPG, interferon, interleukins 4 and 12 are secreted by B cells and dendritic cells. The figure on the right provides a possible mechanistic overview of how increased oxidative stress, inflammation and hyperglycemia can initiate a cascade of suppression of osteoblasts and activation of osteoclasts via both the innate and adaptive immune system. The role of the adaptive immune system and immune complexes in particular will be further elaborated in the slides discussing rheumatoid arthritis. Taken together, the following observations support the role of the immune system and cytokines in osteoporosis. Low estrogen increases mononuclear interleukin-1 production, and rancol is also upregulated in postmenopausal women. Also, a higher TNF-alpha expression occurs after menopause. In addition, aging is associated with a pro-inflammatory state termed inflammaging that results in the overproduction of bone-resorbing cytokines by macrophages. This inflammation is also witnessed in other degenerative processes seen in aging, such as atherosclerosis, dementia, and sarcopenia. In the next slide, we will focus on the mechanisms induced in bone by inflammation and infection, as prototype diseases, rheumatoid arthritis and osteomyelitis will be discussed. Rheumatoid arthritis is an immune-mediated disease that is characterized by local inflammation and bone destruction in joints. Two cell types are central to the disease pathophysiology: CD4-positive Th17 cells and synovial fibroblasts. The resulting excessive osteoclast activation results in bone destruction. Osteomyelitis, on the other hand, is caused by infection with a microorganism, and the resulting inflammatory cascade leads to bone destruction. Intriguingly, this disease can have a relapsing course even after successful therapy. Starting with rheumatoid arthritis, this disease is characterized by three separate phases. During the initiation phase, an immune response is triggered by an assumed antigen, and the innate immune system cells, in particular macrophages and dendritic cells, will produce interleukin-6, interleukin-23, and tumor growth factor beta, that will in turn induce differentiation of Th17 cells. Subsequently, Th17 cells will promote B cells to produce arthritogenic autoantibodies. This entire process becomes self-sustaining once sufficient amounts of autoantibodies have been produced, or because of hyperactivation of the innate immune system. Following the initiation phase, the inflammation phase is when the disease becomes symptomatic. At that time, Th17 cells become able to activate innate immune cells by secreting interleukin-17. That in turn will implicate synovial fibroblasts in initiating a self-sustaining loop. The resulting upregulation of pro-inflammatory cytokines and matrix-degrading enzymes amplify inflammation, promoting migration of Th17 cells into the joints. The third phase of rheumatoid arthritis is when bone destruction becomes apparent. Again, the Th17 cell is pivotal in this process by inducing rankle expression that will promote the maturation and function of osteoclasts. In addition, interleukin-17 synergistically upregulates pro-inflammatory osteoclastogenic cytokines, including interleukin-1, interleukin-6, and TNF-alpha. Having discussed rheumatoid arthritis, let's now focus on osteoarthritis, which is the most common cause of arthritis and an increasing public health problem, owing to an aging population and an increase in acquired risk factors such as obesity. The condition is characterized by progressive articular cartilage degradation and is driven by cartilage matrix catabolic effects and anti-anabolic effects of chondrocytes. However, changes are not limited to cartilage, but also include subchondral bone, synovium, articular muscles, tendons, and ligaments. One of the earliest changes in osteoarthritis is subchondral bone angiogenesis, which is mediated by tumor growth factor beta. This is followed by macroscopic synovitis and bone erosion in middle and late stages. Currently, it is believed that the initial meniscal or hyaline articular cartilage damage and the effects of aging both result in an increase of damage-associated molecular patterns, also called DAMPs. These include degradation products of cartilage extracellular matrix proteins, proteoglycans constituents, free fatty acids, and the debris from dead or apoptotic cells. These DAMPs can start two independent processes. First, through activation of the complement system, where the classical, alternative, and membrane attack pathways will lead to progression of osteoarthritis and chondrocyte death. Paradoxically, this process will in turn lead to an increase in DAMPs, amplifying the process. Secondly, DAMPs are able to bind to pattern recognition receptors, or PRRs, including the toll-like receptor family and RAGE. This will result in the expression of the classic pro-inflammatory cytokines interleukin-1 beta, interleukin-8, and tumor necrosis factor beta. The resulting inflammation and synovial proliferation accelerates tissue destruction via MMPs, increases cellular oxidative stress, and impairs resolution of cell stress. Recently, evidence also suggests that hypoxia-inducible factor II alpha and metal regulatory transcriptional factor 1 are critical go signals within the chondrocyte, reprogramming these cells into a pro-catabolic phenotype. Proteins involved in cellular bioenergy sensing, such as AMPK and SIRT1, exert inhibitory effects of these go signals and are markedly reduced in osteoarthritis, thus making them potential therapeutic targets. Next, we will discuss the mechanisms underlying osteomyelitis. In children, infection occurs mostly via hematogenous routes and affects long bones, whereas in adults, vertebrae are more commonly affected. Contiguous osteomyelitis is most frequently secondary to trauma or surgery, such as the infected total joint arthroplasty. The clinical assessment and choice of treatment requires consideration of the condition of the host, including immune status, functional impairment, the involved site, and the extent of bony necrosis. The Cherney classification can be used to that purpose, distinguishing medullary osteomyelitis, superficial osteomyelitis affecting the outer surface, well-marginated sequestration of cortical bone, and permeative destructive lesions causing instability. Common causative microorganisms of osteomyelitis include Staphylococcus aureus and Salmonella species. The clinical picture is characterized by bone resorption and abnormal bone formation, as witnessed by the involucron. Intriguingly, osteomyelitis can recur even after successful antibiotic treatment and without apparent cause. Possible mechanisms include antibiotic resistance and biofilm formation, but also direct invasion of microorganisms into osteoblasts, where they will be protected from the immune system response. There is also evidence that bone cells are implicated in the inflammatory process, as we will see on the next slide. The underlying mechanism is summarized in the figure on the right. In brief, osteoblasts express toll-like receptors that can bind microbacterial products such as lipopolysaccharide endotoxin and flagellin. As a result, T-cell attracting chemokines will be secreted to initiate an adaptive immune response. At this stage, osteoblasts can become true antigen-presenting cells binding with T-cells through the major histocompatibility complex 2 receptor and contribute to worsening inflammation. In essence, what follows involves a decoupling of the otherwise closely orchestrated process of bone formation and resorption. After bacterial invasion, trail will be expressed by the compromised osteoblast that promotes apoptosis after binding to the death receptor. Not only does this reduce the number of bone-producing cells, but trail is also a ligand of OPG, as discussed earlier in this webinar, so this effectively reduces the concentration of OPG that is available to bind rankle and to inhibit resorption in the microenvironment. In addition, MCSF and rankle secretion is upregulated in both osteoblasts and activated T cells, effectively releasing control of osteoclast activity, resulting in bone resorption. To conclude this webinar, we will briefly review the mechanisms underlying bone metastases, which are a common complication of advanced cancer, occurring in 65 to 80% of patients. Bone metastases induce a vicious cycle of osteoblast and osteoclast recruitment, freeing growth factors from the bone matrix that are used for tumor growth and expansion. Interestingly, the concept of a pre-metastatic niche has emerged, with evidence suggesting that a primary tumor can prepare future sites of bone metastasis by producing circulating systemic factors, including the well-known parathyroid hormone-related peptide. The preponderance of some tumors to form bone metastases is not coincidental, with clear evidence that tumor cells are attracted to the bone marrow endothelium via integrins, chemokines, bone morphogenic proteins, and other mechanisms. This cartoon summarizes the process of bone metastatic cancer, with circulating tumor cells homing to the bone marrow endothelium, penetrating the blood vessel wall and colonizing the bone marrow microenvironment. Indeed, tumor cells are able to expel resident bone marrow stem cells from their niche and replace them. Ultimately, through complex interactions with local cells, a micrometastasis will form and remain dormant until further expansion occurs. Some of the mediators involved in these complex interactions are summarized in this slide. TGF-beta, released from the bone matrix, induces tumor PTHrP production. In parallel, the transcription factor GLI2, which is part of the hedgehog signaling pathway, is overexpressed in tumor cells and amplifies this PTHrP secretion. The tumor-produced MMPs, by activity of RUNX, not only facilitate stromal invasion by tumor cells, they also increase the locally active rankle by cleavage of precursors. Another important paracrine mechanism involves the JAK1 notch signaling pathway that increases the interleukin-6 production, which directly benefits tumor cells and subsequently osteoclastogenesis. Finally, hypoxia in the metastatic niche is detrimental to bone as well, as HIF1-alpha inhibits osteoblast differentiation and promotes osteoclast function. Ultimately, the entire cascade of increased bone resorption induced by bone metastases converge on a single goal: to provide the growing tumor with a survival advantage by benefiting from the abundance of growth factors released from the resorbed bone matrix. Indeed, tumor growth factor beta directly stimulates tumor growth, while the released calcium can interact with calcium-sensing receptors that inhibit tumor apoptosis, promote tumor proliferation, and promote PTHrP production. Likewise, osteopontin will promote tumor growth, and bone Ciala proteins enhance tumor survival and migration. The very complex pathways discussed in the previous slides are summarized in this cartoon for your reference. It is clear that the tumor cell has a central steering role in rewiring the control mechanisms that govern normal bone turnover. Through production of PTHrP, interleukin-6 and TNF, osteoclasts are activated to resorb bone. Matrix metalloproteinases, or MMPs, are secreted to facilitate invasion and rankle production. The effects on osteoblasts are equally complex and vary between tumor types, involving DICOF1, JAGAT1 notch, BMPs, and endothelin-1. And while you digest these fascinating interactions, this is a good opportunity to recommend the brilliant paper from Kathy Weilbacher on this topic, and from which this figure was reproduced. The full text of this paper is freely available via PubMed through the QR code provided. The phenotype of bone metastases is determined by the differential expression of osteopontin versus bone Ciala protein in breast and prostate cancers, and has been proposed as a potential switch between osteolytic versus osteoblastic presentation. The Wnt signaling pathway is also involved, as the inhibitor DICOF1 has a crucial role in osteolytic skeletal metastasis, in which osteoblast formation is suppressed and osteoclast activity is enhanced, for example in multiple myeloma. Conversely, tumor-derived endothelin-1 decreases osteoblast DICOF1 expression and causes deregulated formation of new bone, as observed in prostate cancer bone metastases. Interestingly, reports suggest that cancer cells can fuse with macrophages or can induce the fusion of osteoclast precursors, leading to mature osteoclasts and increased function. This identification of tumor cells with osteoclast properties show that tumor cells are able to behave like bone cells in some circumstances, and this phenomenon is known as osteomimicry. But also through a process known as epithelial mesenchymal transition, or EMT, can tumor cells transdifferentiate to mesenchymal cells capable of osteoblast function, contributing to osteoblastic phenotype of metastases. Finally, cancer cells may force marrow cells into osteoblast lineage and induce osteoblast proliferation. The impact of bone metastases on the structural integrity of bone is well documented, and even osteoblastic metastases consisting of woven bone are structurally immature and of poor quality. Patients are therefore prone to develop pain, hypercalcemia, and pathologic fractures that may even lead to spinal cord compression, the most feared symptomatic skeletal event, or SSE. To make matters worse, cancer-associated bone pain is extremely difficult to treat and is often opioid resistant. Bone is densely innervated by sensory afferent and sympathetic neurons in the periosteum and intramedullary bone. The acidic environment produced by the resorbing osteoclasts activates the acid-sensing transient receptor potential vanilloid type 1 neurons, which upregulate calcitonin gene-related peptide in the dorsal root ganglia, which is associated with inflammatory pain. Tumor cells, on the other hand, secrete nerve growth factor and endothelin-1 that can activate pain neurons directly. In conclusion, bone is a composite tissue that consists of mineral, matrix, and cells. Osteoblasts and osteoclasts are key effector cells of bone modeling and remodeling, and bone has structural, homeostatic, and endocrine roles. Several growth factors, cytokines, hormones, and transcription factors regulate bone homeostasis in different control networks. Finally, bone disease is characterized by complex interactions of bone cells with the immune system, pathogens, or tumor cells. So, we have covered a lot of ground in this webinar, and I hope I have been able to spark your interest in the pathophysiological mechanism of some common bone disorders, as well as the many pathways governing normal bone physiology. I thank you for your attention, and goodbye.